we'll just get going just at noon. Okay, well, welcome everyone to the CMDA monthly meeting for August. We're so glad that you joined us today. And we're still virtual, which I imagine will be for quite a while. So we really appreciate you taking the hour to spend it with us. So welcome everyone. We're going to restart our updates from CHCA and CDPHE. We thought that might be helpful. So this is our first month to reintroduce that. And we'll start off with an update from Ann Kokish from CHCA. Ann?
Thank you, Dr. Eber. Well, good afternoon, everyone. I'm so sad that we still cannot meet in person, but hopefully sometime. A few things that CHCA has been looking at with members. I know all of you have heard of the point of care antigen testing machines that are being sent out. 4 have now been sent to Colorado. I don't believe any of them have been received yet. You might know it's Mountain Vista Healthcare, Mountain Vista Estates, Center at Centennial, and Life Care Center of Stonegate that are expecting them. We have reached out to them and hope to hear from them as soon as they receive them. I know the state lab is working on some training related to using the machines, which seems to be quite a challenge in the other states that have received them already. It seems that the criteria for getting one of the machines is that you've had 3 or more new cases in the last week, or you have had one new case in the last week and you previously had been all negative for COVID.
So
or
I'm a little confused at that. I'm the medical director at Stonegate and they haven't had any residents with COVID.
Okay, I mean, there are 2 or 3 more. Oh, great, I'm glad you're on. Inadequate access to testing is one of the criteria. At least 1 resident death for COVID in the last week, or at least 1 new staff member case in the last week. Are any of those present?
Well, you know, they've had maybe, I want to say 2 or 3 staff cases, no resident cases. They do have, I mean, they're getting pretty good testing from most of theirs go to National Jewish.
Great.
But yeah, the new residents.
To be honest with you, it sounds a little bit more random than just these 5 points that CMS said.
That would not have been who I would have picked.
Right. American
I mean,
Association.
They're good organizers.
Yeah. AHCA has highly recommended that the buildings communicate very closely with their local health department, particularly related to the guidelines, which seem at very best confusing. And so I think all of that will be worked on, and I know the strike force is also working on it. Another area that, another area that is taking some effort on everyone's part right now is EM Resource, which, as you know, is now a requirement of every nursing home to submit data to EM Resource. Consequently, we are now submitting data to NHSN, EM Resource, and there's still some attempt to possibly get those 2 systems to interact so that we aren't doing quite as much duplicative data reporting. Another area that we're focusing on, and if Dr. LaRocca is on the phone, she might even have additional information, but you know, HHS is releasing another $5 billion to nursing homes. In order to qualify for any of that additional financing, the facility is going to have to complete, it sounds like 23 modules of infection control training, and it also sounds like it will not be just 1 designated infection preventionist. It will be staff engagement and staff that also need to complete the modules. So that will be quite a challenge.
And this is Christine. I don't have anything to add to that. Thanks. The quality improvement organizations were asked to provide content for those modules to CMS, but CMS is doing the developing.
Oh, interesting. Thank you. Thank you. You likely know that the return to work guidance has been updated. I won't go through that unless anyone has any questions on it and would like me to go through it, then I'm happy to. You also likely know that protective eyewear, either goggles or face shields, I believe are now required in all resident areas in all nursing homes that have any evidence, even in the outside community, of COVID. So there would be few and far between that would not have to implement that. But I'm hoping Joe will address that a little bit more for us. Polis has still kept Colorado, I believe, at a safer at home status, which would then dictate the use of face shields. The other things that I get continuous questions on are whether or not communal dining, as long as people can distance 6 feet and have appropriate protective equipment on, is allowed. It's my opinion it is not allowed. That's the guidance that we are giving, and that full PPE, now including face shields, is required for new admits for the full 14 days, whether they are presumptive or even if they've had a negative COVID test. So those are kind of our hot topics. On August 6th, Mel Roth-Larson from CDPHE is going to do a webinar training on EM resource. So you might mention that to your buildings. It will be through CHCA, but just a short how-to webinar now that it is a requirement. Thank you, Dr. Eber. That's really all I have, unless there are any questions.
Hey, Ann, this is Craig.
Yeah.
Just one comment on the protective eyewear. The HAN that just came out on July 31st says it's recommended for staff providing direct patient care, which is a little bit in opposition to what the CDC put out a week earlier, that they wanted to see it on everybody. But I think that where we've landed is if you're in a direct patient care area, you should have you should have eye protection.
That's a great clarification. Thank you very much, Dr. Gahm. So if I'm walking down a hall in a residence area, would I have a face shield or goggle requirement?
What I've been telling our staff is make sure you have some sort of eye protection on. If you're just walking down the hall and you're not taking care of patients, probably even just your glasses are enough. If you're going to be around patients or going to stay in that area, then you probably want goggles or a face shield.
I agree. If Joe is on, and I know Joe is planning on speaking, Joe, please correct me on everything that I said that is incorrect now. It sounded very clear on the last Wednesday call, which was before the HAN was released, so that protective eyewear was required. So maybe Joe can help us with that. But thank you, Dr. Gahm.
Sure.
Thank you so much.
I'm sorry, this is Allison. There's a question in the chat box asking if the safety glasses that FEMA provided would be acceptable, if either Dr. Gahm or Joe or anybody wants to address that question as well.
I would say yes, because none of the guidance has gone to that degree yet with the goggles. What you're really trying to do is just keep your hands out of your eyes. And if somebody happens to cough on you, you don't want it to come into your eyes.
Thank you.
Ryan, and I think as long as it protects the sides as well. So yeah.
Yeah, so we've even seen some creatively available wings that you can attach to glasses that would actually serve the purpose.
Thank you so much, Ann and Dr. Gahm. Joe, do you want to give your update now as well?
Sure, I'd like to do that. It's good just to talk to everybody today. And I guess I'll start with the goggles or the face shields. And it's interesting, we had this discussion yesterday with our folks from epidemiology who, put out the HAN as well as updated the checklist. And they both say something just a tiny bit different. So, it is recommended they should wear goggles or glasses. I think part of the feeling also is that put them on your face when you start your shift and just leave them on. You have less chance of, rubbing your eyes or contaminating them by taking them off and putting them on and not remembering you needed to do hand hygiene.
Oh, Joe, we're losing you a little bit. I think maybe you have, that's much better.
Is that better?
If everyone else can mute themselves so we can get rid of some of the background noise, that would be very helpful. Thank you.
Okay. So as I was saying, we talked about, putting them on at the beginning of your shift. That way, and just leaving them on, that way you don't forget to put them back on when you walk into a resident room. Also, you don't have to worry about contaminating them if you forget to do hand hygiene on your hands when you take them off or put them on. So it just makes sense to put them on and leave them on. Also, if you happen to pass a resident in the hallway who doesn't have a mask on, it's a way to protect yourself during that time too. And I know the surveyors are instructed to put them on when they enter and leave them on as long as they are in your building. So that's what we would want to see as well. At this point, we are not writing citations if you don't have them on, if that's all we see. If we have a lot of other issues with not wearing PPE or not wearing it correctly, it could be contained in a tag that way, but we're not going to write a deficiency just for not their use. Since there seems to be some differences in how they need to be used. I also wanted to just mention the outdoor visitation. I know many of your homes have started doing that, putting visitation in place. Do remember the medical director does have to approve of the outdoor visitation plan, so make sure you have done that. I also have heard from one family who has where their family member lives has not started outdoor visitation because the medical director will not approve the plan, does not want to have outdoor visitation because they've not had COVID in the building and they don't want it in the building, which is understandable. But we also need to remember residents do have the right to have visitation when it's safe to do that. And with the public health order stating that outdoor visitation can take place, the nursing homes need to be doing that and not just not doing it because you don't, not just because, but because you don't want to have COVID in the building. Do, have a good plan so you can protect everybody. Our surveys are going to continue. Each week we receive a list from CMS for the surveys that we need to complete the next week. And those surveys are based on information that each home has provided to the NHS in the week before. What we are seeing is sometimes incorrect information is being reported on the NHSN. So we will get out to a nursing home to do a survey and they don't have any new cases, they don't have an outbreak. So please make sure the information you are putting on the NHSN report is correct. We've been to one place now twice this month because they have reported new cases and they haven't had any new cases since April. So it's really important that you work with the people at, your folks at your homes that are doing that to make sure the reporting is correct. because we don't need to be out there doing a survey if we don't need to be out there. You don't want us there. We don't necessarily want to be there if we don't need to be. So please help them make sure that's all correct. Then I was going to talk about signing up for the EMS resource, but Ann already did that, and I'm glad they're going to be doing some training on that as well. So I think that's all. Well, actually, surveyors, we're figuring out how to get surveyors tested now on a weekly or some kind of basis. So we will have more information on that coming up in the next couple of weeks. So I think that's all. There are no questions.
Joe,
Joe, you
Joe,
got a couple questions.
so this,
Sorry, here in the text box. One of the questions is to clean the goggles and face shields between residents.
I think the guidance is to clean them when they are soiled, visibly soiled, or they are soiled.
Okay.
I don't know, Dr. Gahm or somebody may know more than I know about that.
yeah, I think the idea would be, I think the expectation would be like everything else, to wipe it off with an alcohol-based wipe of some sort between patients and after use.
Thank you.
And Joe, the medical director, if that's somebody that you'd like to, a name you'd like to share with Leslie, I'm sure the board or myself, somebody would be more than happy to reach out to that medical director.
Okay, sure.
Yeah, absolutely. Allison, are there any more questions from the chat box?
Nope. You answered the second one, so I think we're good.
Joe, this is Christine. Could I ask a question? Christine LaRocca. Is the confusion with going out to that home that's reporting cases when they haven't had any since April, is the confusion about the difference between incidence and prevalence? Because I wonder if there could be some training around that.
Oh, and that may be, I'm really not sure why. I know when we were there the first time, we asked them to really check and make sure that they were reporting things correctly. I don't know. And then when we were there again today, it was, well, we still haven't had any, and we don't know why. So it could be. I do know that certainly, I know you all do training on how to do that, but our HAI coordinator also does. So we can have them reach out to either someone at Telegen or our HAI just to make sure they are reporting correctly, because it's a big deal if you don't report correctly. I do want to say, as of this week, 100% of all nursing homes in Colorado are signed up and reported last week. So that was the first time. So, and some of you, or some, have had to pay fines for not reporting every week. So again, even if they've signed up, help remind them that they need to report every week or they get a fine from CMS.
Thank you so much. We have some clarification from the chat box that I think is really helpful from Dr. Marquette. My understanding is that anything on the face does not need to be cleaned routinely between residents, but hand hygiene needs to be performed anytime after touching the eye protection. I agree with that. And so that is a little bit more of clarification. Is there, thank you so much, Joe, for your update. Thank you, Ann. Is there anybody else who has any other questions for Joe or Ann? Thank you, guys. All right, we're going to move around. We have a lot of special guests today, and I'm really going to turn this over to our Vice President, Dr. Singh Palat, and we are going to have a panel of outstanding docs that we're really lucky to have the time today to share their knowledge and experience. So, Singh?
Thank you. Yes, we're excited to have 4 people talking on our panel today. And one of the questions on the panel is about how we can partner with our public health agencies. So thank you so much, Joe, and everyone else for being here and bringing your updates. Our goals for today on the next slide are to learn from each other, to learn from people who have been through outbreaks of COVID-19 here in Colorado. And we'd like to leave today's session with some tips or pearls on how to prepare for future outbreaks. So let me introduce our panelists. We have Dr. Joyce Mobley, who, as we heard earlier, is the medical director at Stonegate, and she was the medical director at Villa Manor at the time when they had a very large deadly outbreak. We have Dr. Reza Esfahani. He is a multi-facility medical director and currently at Mountain Vista, which had a large deadly outbreak. Dr. Rebecca Jackson is the medical director with Front Range Geriatrics, and she's part of a health system that has North Shore Acute Care and Rehab, which experienced the first Colorado COVID outbreak. And we have Dr. Karyn Leible, who is the medical director at North Shore Rehab. She is a former president of AMDA. We're very honored to have you here, Dr. Leible, as well as all of our panelists and everyone here on the call today. So let's start with our first slide and question. In July, the CDC announced the development of a new test that could detect both influenza and SARS-CoV-2 in one swab. And CMS also announced, as we heard from Ann Kokish, the point of care antigen testing will be delivered to all nursing facilities in the country, and a handful of facilities here in Colorado are to be getting there shortly. So the testing methods and guidelines are always changing rapidly. For the panel, especially Dr. Jackson and Leible, who were in the very first outbreak in Colorado, how did you know the testing procedures and which people to test? And what would make testing a better process overall?
Yeah, I was starting to laugh. We didn't, because it was the first facility, it was quite challenging. We actually did not know what we were dealing with because we also had influenza A, influenza B, and RSV in our building. I was just fortunate that we had a nurse that came to me after a 4-hour layover in Seoul, Korea, and said, you know, I'm not feeling so good. And we asked to get her tested. Unfortunately, her test was canceled, but a family member of hers came up positive, and then her 2 roommates came up positive, and then she was tested and turned out she was positive. But in the meantime, we started just doing routine temperature checks twice a day, I believe we did, or 2-3 times a day, and oxygen saturations. And then we had, about 4 days later, I had 5 residents develop fevers. We contacted the health department and proceeded from there. We ordered COVID testing. We ordered a respiratory viral panel, and it took days to get back. So we didn't know what we were dealing with. We had to assume that we were dealing with COVID or some sort of respiratory. To be honest, having taught for AMDA and infection control for 20 years, I just kicked right into the flu mode and just treated it like we would if this was a flu outbreak or an RSV outbreak in the facility. Anybody that had any kind of potential symptoms were immediately put on droplet isolation. So that was the beginning, and Rebecca can talk more about the testing from her perspective from the corporate.
Yeah, I mean, it was incredibly delayed at the beginning. I think our first round of testing, we waited 14 days. They sent it to Utah, and there was an earthquake in Utah, so they shipped it to California. And frankly, I don't think all the results were accurate. So we just really couldn't identify where it was at very easily. And we were really only, I went back and looked at the timeline, we were only about 10 days behind that Kirkland facility out in Washington as far as our onset of symptoms for our residents. So a lot of those, the wide range of symptoms that kind of comes with COVID weren't really identified yet. So, it took us a while, but it became very evident that, just even lethargy, not eating as much as normal, some of the GI symptoms were signs. And at the beginning, we were just fighting to get supplies. We actually made a move and changed labs during the middle of the outbreak because we just were fighting to get swabs all the time. And now it's a lot more organized. We've been able to mobilize through the CDPHE lab. If we do have any, like a resident, we would do facility-wide testing of both staff and residents. We even have organized to do that for, if we have more than 2 employees, kind of based on the state and county guidelines. So we went from, just begging for supplies, and now we've been able to mobilize a lot better across our health system at Columbine to do facility-wide testing. So.
Thank you, and I agree that a lot of the skills we learned from influenza can be applied to COVID-19. Dr. Mobley or Dr. Esfahani, other thoughts on testing?
Well, my experience was a little different. I mean, I'm a PRN physician, so although I've been in Villa Manor a lot, off and on, I basically was starting the Monday that we were starting our outbreak. We actually had a nurse that tested positive just prior to that. And that was like on a Friday, I think. By Saturday, we had 6 temperatures down the hall she had worked on. So it was pretty obvious to us that we had COVID. And this was early May now. I mean, we did start ordering tests on anybody who had pretty much anything that was abnormal. But we wouldn't see them for 5 or 6 days. But we pretty much isolated everyone as soon as we thought anything possibly could be wrong. And then right in the middle of that 2-week period was, I think, when President Trump just made this big announcement about everybody testing everyone. So we kind of did that too. So by the end of the 2 weeks, we had a good outlook. But during the middle of it, it was hard to make decisions on isolation because this couple days in, we had it in our isolation unit. I mean, that was already, everyone was using PPE, and then who were you going to vote with who? Because it was all over the building very quickly. So rapid testing would have helped us. I think it was hard to make all the decisions during that time period of who needed to go where, because the tests took us 5 or 6 days to get them. And the staff the same way. And we had a lot of staff members too, so that tested positive.
Having quicker test results would definitely help.
Would definitely have helped. And I'm not in that building now because I was only there for 2 weeks. So I don't know. I'm sure things have changed rapidly now.
And I think that takes us to our next slide. In June, COVID-19 surveillance was recommended for all facilities. What role has surveillance testing had in your facilities, and what needs to be improved for surveillance testing to be effective?
Well, I can kind of speak to, we've been working on this a lot at Columbine. We've been doing a study with CSU where we've been doing weekly testing for the past 8 weeks of mostly staff and residents if they leave the building. It takes a lot of manpower to organize it. So logistically, it's really challenging to coordinate it at facilities. And the other barrier I see is that it's still voluntary. So, and maybe there will be a point where it can be kind of a mandatory piece of being employed at one of these facilities that you kind of are in agreement with that. So, because really when we've talked with CSU, it sounds like you really do need to reach a 70% of your staff in order to make it good surveillance testing, and really that every 7 days is kind of the best standard. So but having a fast, cost-effective test would be ideal. It's really hard to do a test and then we'll have to wait 4 to 5 days for your turnaround. So we're still hoping to implement it because I do think it's mostly staff. I mean, we're the ones that are out in the community. So it's really to protect our residents. That would probably be the ideal thing. The logistics of it, I think, are complicated.
Sure, thank you. Thanks for sharing that experience. We can go on to our next slide, which is applicable to everyone for sure. Dr. Rich Pfeiffer recently highlighted the importance of unified leadership when he mentioned a 3-way partnership leading his organization's pandemic response. How have relationships changed, either strengthened or weakened, among the leadership in your organizations due to the outbreak? And what can we learn from this? Dr. Esfahani, if you'd like to chime in.
Sure. Yes, thank you. Yeah, my experience has been, all the different facilities that we go to, different nursing homes. Of course, as much as we all try to have a unified front and unified leadership prior to the outbreak, was difficult. And specifically when we have facilities where we have multiple provider, physician groups and what have you. But what I have found initially during the outbreak, we had difficulty, but as things settled, we came to realize that, you know, this is one of those things that we all have to work together. All of our physicians, providers, mid-levels, nursing home administrator, and everybody involved. We all have to come together and do the best we can to get through it. And I am thankful for the facilities that I go to, facilities that I am medical director. Unfortunately, 5 facilities that 3 of them I'm medical director and 2 other ones I'm not, have been severely affected by the outbreak. And almost every one of them, I can tell you, toward the end, we learned to work with each other. And that continues today, and I have learned valuable lessons.
Yeah, I would agree. I mean, we kind of organically developed this EOC at Columbine. It's really a interdisciplinary team. I mean, we have nursing leadership, social services is represented, HR. We even have medical equipment be a part of it so that we could keep PPE counts. And everyone from the company owner to the CFO were very supportive. I think that I shout out to the EOC at Columbine, because I don't think I could have had this whole without them. They've just been incredible through this whole experience. So having a team that you can lean on during these times is super important. I would agree.
Yeah, I have to echo that. I mean, I was so caught up in the weeds because really we needed the clinical leadership and actually hands-on taking care of the patients. We had some issues with providers not feeling well, and of course they can't work when they're not feeling well. So I was really grateful to have the system that was able to kind of step in and provide the leadership that I wasn't able to provide while I was actually doing the patient care.
I think as a person coming into a building right at the start, although, I was known to the building, I think leadership is extremely important, because those early days were chaotic. I mean, just crazy. And the different information flowing around was really difficult. And I think the better your leadership and trust you have with your staff prior to an outbreak will serve you well during an outbreak, because you don't develop it in the midst of the chaos, that's for sure. Because it just gets so confusing who's telling you what, where, when, and I felt that even myself, going into the building, like, okay, what PPE do you want me to do where? And it was just hard, and it changed every day too, of course. But
thank you. I agree. It's kind of an ongoing project with the leadership. If you'd like to, we can go on to the next question, or there is a question in the chat box. The question is, what communication strategies did you use for staff and providers, and who did you work with to get everything done?
We were actually doing frequent huddles with the staff, like probably 2 a shift. As the outbreak occurred, the DON would come in, especially as things were changing. Again, we were early on, so things were changing pretty rapidly, whether it be, treatment, whether it be PPE. So the huddles I found were very effective.
Thank you.
And I was not, of course, in the leadership team, but I was the only physician in the building during this time. There was a nurse practitioner, and I did all the medical care. But I don't know, I felt left out of the communication loop. And it would have helped me to be in the communication loop for that time period.
So having frequent communication, and then also being invited to that communication.
Whatever that communication was, yeah, like, I don't know. Because they'd ask me, and I wouldn't know what people were being told.
It's important for all of us. Thank you. If you'd like to, we can go on to the next. Oh, go ahead.
Oh, no, I was just going to say we were doing daily phone calls at the beginning with each facility and all the levels of care that we have in the system. And we've been able to taper it back, but we're still doing weekly updates with everyone in the organization just to make sure that we are trying to stay on top of all the things that are so fluid and changing. But you could definitely see a very dramatic change once the facilities implemented huddles. I really think that communication and it brings the team together too is just so key.
Thank you. Well, nursing facilities have faced unprecedented challenges with PPE, including asking staff to provide homemade gowns and masks. What has helped with PPE shortages and other challenges with PPE in your facilities?
I just called Dr. Jackson.
Can we all do that?
Oh, that's all our CME working on that. When we realized really quickly in that first week that if we continued with our current mask usage, we would have ran out of masks within the week. So we partnered with, there's a local company called Thermal Strike that we partnered with. He's waiting for FDA approval, but it's a dry heat technique. And that way we were able to reuse masks at our non-outbreak facilities. And we continue to use that to conserve PPE because, masks aren't as big of a problem right now, but I think gowns are really a huge issue too. So we've transitioned to the washable, wearable lab coats for our 14-day quarantine patients because we really want to save as much as we can for the fall because not only do we have COVID, we have flu, RSV, all the other things we have to worry about. So.
It sounds like being aware of the situation and then making plans to conserve what you have is kind of a strategy you used.
Yeah, we've used daily, we had a board at the beginning where we looked at daily counts of PPE. I think at the beginning we went through, at the peak of our outbreak at North Shore, it was 2,000 gallons in a week. So it is really important to kind of keep the counts in mind and do it conservation. And the state actually had a great presentation, and that's pretty much what we did for their recommendations. It's like, if patients don't have another MDRO that you have to worry about, you can go wear your gown from a COVID room to another COVID room with hand hygiene in between. It actually got harder to conserve PPE as our outbreaks resolved because we couldn't do that as much anymore. So.
Thank you. Should we go on to the next slide or else address some of the questions in the chat box? Why don't we go to the next slide? Okay. We could batch them or do them in between slides, whatever works. Well, when the California chapter of AMDA had one of their weekly COVID webinars on teaching medical directors how to speak to the media, it was called How a Nursing Home Doc Ended Up on the Rachel Maddow Show. I thought, oh great, there's another skill that I have to know that I didn't even know I had to know. While facing the media is not most medical directors' roles, and I know that you, Dr. Jackson, were quoted in a local news outlet, what extra roles or duties have you performed for your facilities above your regular duties? And what pearls do you have for the rest of us?
I don't know if I have pearls. Anybody who knows me, I'm not really someone who likes to be in the spotlight at all. But yeah, I had to be in the paper, on TV. I talked to senators. I've been on panels at CSU, and it's, I don't know, it's definitely not my style, but I felt like it was super important to show public support to Columbine, reassure our families and our residents that we were trying to do everything we could to keep safe. And just, just the post-acute long-term care setting too, showing that people are there, that we do care. And just in the setting of all the bad press, I felt like it's important to be visible at that point.
Great, thank you so much. If you'd like to, we can turn to the chat box. There are definitely some questions from the audience. Sylvia was asking that she has, Dr. Esfahani, were you trying to comment? Okay, well, Sylvia was asking about, she's been trying to go see her patients in the facility. Recently, providers were not allowed in. The telehealth visits were very difficult. Providers weren't able to go in, but the facility was letting patients in and out. How do you handle that?
We decided not to pull providers from the building. We talked about doing telemedicine. We felt like it was important for us to be there on the front lines with our nursing staff and everyone else who was caring for these residents. Dr. Leible was very adamant that we didn't do that. And I do think it would have been too hard to do that via telemedicine. I think that's a challenge. It would be very challenging. Where we used telemedicine was when I was down there, I was using telemedicine for my COVID-free buildings so that I, wasn't going into those buildings and then do regulatory visits and that kind of thing via telemedicine. But yeah, I would encourage buildings to allow providers to come in, hospice to come in, because that's a huge support network for the facility, the nursing staff. I don't know what other people's experiences are, but.
There's a great response from Dr. Greg Gahm in the chat box. You can read it about doing the weekly testing for staff and making sure that they're not bringing in COVID. Two more questions from the chat box, then we can get back to the slides. Dr. Levy is saying, we were implementing trauma-informed care when this hit. How are you all navigating the trauma you have all experienced now? And I imagine that's trauma both to the providers and to the residents and staff.
Talking about how it affected us personally?
We could go there for sure.
Trauma or
and I think they're talking about the trauma-informed care for the residents that we're required to do for CMS.
Okay.
But certainly there's been trauma to the staff as well. Dr. Mobley, do you have a comment about that?
Well, I think it's mentally very hard, particularly if, during an outbreak, there was a lot of fear and concern, and people didn't know what to do. And I know myself, it was one of the most traumatizing 2 weeks, I think, of my career that I worked, during that outbreak. And so I think, and then, because so many staff and myself all got COVID too, you then have the added, trauma to everyone, to say nothing, of course, the patients who, the significant amount of, difficult interactions that happened during that time, during all the deaths and that sort of thing. So there's certainly is trauma related to having a major outbreak, that's for sure.
Is there anything, Dr. Mobley, that would have made it easier?
I'm sorry?
Is there anything that would have made it easier or that we could be doing to support our providers moving forward?
I guess that's a good question, and I'm not sure. You really realize how bad it's going to be till you're living it, and I think that was kind of the way it was. It was like, this isn't really happening, isn't it? Luckily, the nurse practitioner and I who worked together literally supported each other for that 2 weeks. I bet we talked, I'd never even met her before, and we talked 4 or 5 times a day, and just to, I think, to get ourselves through it and to make sure we were on the same pages and stuff, so that kind of camaraderie and stuff was very important.
We need to be there for each other.
Yeah,
We need to be there for each other.
Yeah, CPHP also provided some support as well, because I had similar issues. I reached out to a lot of my colleagues, many of you in the CMDA, including Greg Gahm at one point, but I found that very helpful. I think just you really needed to reach out. We were at war. That's what it felt like. You were really on the front lines. You really didn't know what to expect. Every day you'd come in, you weren't sure. There were so many, especially early on, there were so many unknowns. But I think having the support of the organization like I did, and Rebecca was absolutely incredible with me, and then the support of people like my colleagues at CMDA and also in AMDA was just really, really helpful.
You need something.
So again, the answer is to call Dr. Jackson.
Well, no.
There's some great.
Our local health
great.
had some support groups. I think it would be great to see ones that were like targeted towards providers, because you know, I think some of that, I think it'd be really great to have colleagues like in a support group that you could like process through all of that, because there's a tremendous amount of anxiety and grief that comes with these outbreaks. And also just like, I think probably a lot of us are just grieving the change to our profession. I mean, like I love geriatrics because I can hug my patients and be part of their families and have that intimate relationship. And it's really changed a lot of that. And it'd be great to, I mean, I know there's some organizations down in Eber that are looking at trying to do that, and hopefully they'll be able to create that for people, because I think it's wonderful to have something for providers.
And I found the staff would come to me, you know, if you would talk to them. I mean, remember having this wonderful, well, not wonderful conversation, but with this little housekeeper who's been at Bill Manor forever. And she was just so frightened, you know. And so there's a lot of that kind of thing that you're kind of doing during that time that's a little outside your normal.
Yeah, thank you all for sharing. In case we don't get to it later on, there is a slide on here that features a podcast with Dr. Leah Watson, a geriatric psychiatrist, who shares some of her tips on supporting providers. We can go on to our next slide. The National Center for Health Statistics has published a guide on how to certify deaths with COVID-19. There's a short document and video. When you certified COVID-19 deaths, how do you figure out what to list on the death certificate, and how are your diagnoses being accepted by others? And by the way, I just got a text message from Dr. Reza Esfahani. He got pulled away for a patient issue. So it's you three.
I think that one of the problems at the beginning, because we didn't have great testing, so if you said it was a probable death, the media was so fixated on the numbers that it was hard, because you want to be honest about it, but then it get counted against you, and so it was kind of this. It felt very conflicted at the beginning. You know, now I don't think there's that focus on the numbers like there was at the very beginning of the outbreak. I don't know, Karyn, what your thoughts are on that.
Yeah, that's true. It was tough with the testing. I mean, we did have some people that had routine pneumonia. Again, we still had flu in the building, and we had RSV. And there were a few people that died from sepsis. Don't really know what the cause was. What was helpful is there was some guidance that came out from the EDR, from the whatever it is, the death certificate place, that I was kind of using in terms of helping to fill out those death certificates. I mean, really, I can identify 6 patients that we had that had positive testing. That I was actually able to list COVID as being their cause of death, or the pneumonia related to COVID as their cause of death. So,
yeah, I know during May, when our outbreak was early May, all that stuff was being talked about in the media and everywhere else. And I think that's when they changed some of the Colorado statistics. And I was sort of if COVID was really, even though maybe they were an aspiration pneumonia risk and they got an aspiration, but if COVID caused it, I wanted to like put that there. But I know that there were other facilities that I go to that had outbreaks. And I know some places I went to, I felt like there was more, not wanting to hide it really, but you know, to be kind of less like, we don't want to get looked at badly, so you know, be careful what you put on the death certificate attitude. So I don't know if that's changing now, because I haven't done any of those recently, but I've been in enough different facilities now, and I felt like there's been a different kind of attitude in various places about how aggressive they wanted to be calling it COVID.
Have a judgment call in some cases.
Yeah, and some of it is people didn't want, I don't know if they felt pressured by somebody, you know, to not want to be known as a COVID facility, so therefore don't do that. I don't know. I felt a little bit of that when I've talked to other facilities and stuff.
yeah, I think early on there was a lot of politics too, not wanting, because people were kind of reeling from what happened in Kirkland or up in Washington State, and there was some avoidance. I mean, we were even asked to swab people post-mortem to sort of see if we could identify COVID as a potential cause. So it was kind of difficult in the beginning. I'm glad that's all kind of calmed down now.
Thank you for that. Let's go to the next slide. This is the one this features a podcast on AMDA On The Go, interviewing Dr. Leah Watson, geriatric psychiatrist. And if anyone wants some ideas on how to support themselves or other people in this industry, this is a great podcast. And there is a suggestion in the chat box from Dr. Eber. Perhaps CMDA can provide a monthly Zoom meeting specifically for sharing experiences and supporting each other. But thank you for thinking about that as a resource, Dr. Eber. We should definitely consider it.
Yes, I think actually that was from Travis.
Oh.
But he's welcome. I'm happy to take that credit, but thank you, Travis, for that suggestion. Thank you.
Absolutely. Wait, let's go on to the next slide. So the next slide is, again, Dr. Leah Watson, geriatric psychiatrist from Colorado, was quoted in JAMA recently discussing the devastating toll that restricting visitors has had on facility residents to combat. So to combat social isolation, what innovative solutions have you seen in your facilities, and what challenges are you seeing during the reopening process?
My favorite was when our elders would be cleared from COVID, the nurses would go and do a COVID dance. I forget what song they would sing, but the residents just loved it. It was really difficult, I think, especially in the beginning, especially with like paper plates and really the strict isolation. The staff did an amazing job with trying to keep the patients engaged. We weren't, because we were able to isolate it to one unit. On that unit, we weren't doing the room, the hall things, but the staff would come in and do different things with the patients. Some of the social service would actually volunteer to come in and sit and talk with the patients. My patients, and this is going to make me tear up, but some of my patients who were actually dying from COVID, I had CNAs that would just kind of go in and just sit and hold their hand and just be with them. It was pretty touching. So.
Yeah, I can't say enough about our CNA and social services and activity staff, and they've just been, I mean, I'll get sentimental too. They've been tremendous through this entire process and really shouldered a huge burden through these outbreaks. And they love these residents so much. So it's been really hard on them, but we appreciate all the effort they've done.
Thank you. It's an amazing thing where just doing something simple like holding someone's hand can be so extraordinary. Yeah. Let's move on to our last slide. And Travis, it's the one with the picture of the CMDA logo. Between the infection control surveys and consulting all of the epidemiologists, COVID-19 has led to many of us interacting with our public health departments more now than ever before. How have your interactions been with the public health department, and how can we strengthen our collaborations with the health departments, the CDPHE, and ourselves?
You know, from my perspective, I think it evolved. I think everyone was kind of, because it came to us so early, we had just finished a survey, and it was the following week that we started seeing symptoms in our building. I think initially there was just a lot of collaboration going back and forth about PPE, how to do it, room isolations, when to do testing. I think Rebecca can speak to it more. I actually had to pull out of the weekly calls, but the health department is pretty much there with us, hand in hand, trying to figure out what we were going to do next, because there wasn't a lot of information at the time. But Rebecca, do you want to?
Oh yeah, I mean, I guess that's if there is a benefit to going first, that was one of the benefits, I think, is that we were able to kind of establish really strong relationships and ties with a lot of the CDPHE group, and also with our local health departments too. And they are a tremendous resource. And they probably get sick of me and other people from our group emailing them all the time, but they always respond, and they're always kind and willing to partner with us. And the same goes for like Joe Tansey has been really tremendous, and she always emails us back too. So, I mean, I think using your resources and not being afraid to reach out to them for assistance, because when you need them, they are there for you, and they've been really great. So.
And I kind of had the opposite experience, because I wasn't involved with anybody on anything about, from as far as out by the facility. And I sort of felt like during the time I was there that it was very confusing to me, between what the county was saying, our corporate structure was saying. Now, it was obviously a very confusing time as everybody got into this and stuff. And there was a lot going on. And I think everyone, it felt very confusing to me because from day to day, I couldn't figure out what the recommendations were. And I know that, I think the county was talking to the leadership in the center, but I wasn't really involved in that. And then, so to me, it felt like I was out there on my own, doing whatever that was at the time, which I wasn't sure myself. And I know the state came in during it, and but there was nothing, a conversation that really came up over that. And so it would have been helpful to me actually to feel like I was being supported by the you know, the various, whether it's the county or the state. I know early on in ours, like on, you know, like a couple days in, the staff was, all they wanted to do was call their senators, call the governor, you know, call in anybody who would help them. And I sort of felt the same way. Like, I want to put a sign out there and says, help us, because it kind of wasn't feeling like it was coming. But they were all, you know, we said, no, don't call the senators and the governor and all that. But that was kind of what the feeling was, is please help.
Maybe during those chaotic times, it's a great time to keep that medical director involved. Maybe that would help you feel more in the loop with things and then provide some medical advice.
Particularly with the county, that would, because I think they were the main one, you know, I don't know what happened when the state came in, but I know they were there. But I think particularly the county was having more, you know, discussions. Maybe if I'd been involved, I would have felt a little more connected, because I really felt very disconnected, as did the nurse practitioner, and we were the ones, you know, providing the medical care at that point. So we felt pretty disconnected from everyone.
Yeah.
Great. Thank you, Dr. Mobley. Maybe this is a great segue, hopefully, to the next update from Drs. Eber and Gahm about the strike force. But at this time, we say thank you very much to our panelists. If there are any last minute questions for the panel or for any of us, go ahead and throw it in the chat box, but we'll let you go ahead and do your update, Dr. Eber. Thank you.
Thank you so much, Dr. Palat, and thank you to all of the panelists. It's just been a tremendous opportunity. Thank you for taking the time, and thank you for all that you've done for your patients and facility. This is going to be the quickest update, and if it's of interest, I think Dr. Gahm and I would be happy to do an additional update next month as well. So it's going to be very quick. So I'm going to do half the update, and then Dr. Gahm is going to do the other half. For the strike force, you know, they are continuing to be dedicated to doing surveillance in facilities. And if you are interested in doing that, you can reach out to the health department, CDPHE, and see if you can also get tests weekly to test staff and residents that leave weekly, like for dialysis. And at first, the strike force wanted to do 8 weeks, but that's going to be extended. And so that's great news, that we'll continue to do the surveillance in Colorado, and the strike force will support that. There's opportunities for providers, of course, to get tested within this surveillance testing. And so that's something that CMDA and Dr. Gahm and Dr. LaRocca and Dr. Levy have worked really, really hard with the strike force to make sure that all providers are included in the surveillance. We don't want to be the vector. And so it's written into the strike force recommendations that if you're going to a facility, ask that facility if they are doing surveillance. You can be included in that for free, and you can have weekly testing. And it's wonderful. We just heard from Tansey that surveyors are now going to be tested, and I hope weekly, and I hope quickly, so that we make sure none of us are the vectors. The last thing I wanted to touch upon for my part of the strike force update is, of course, you have heard from the CDC, and the strike force is supporting this as well, is there's no need now to test for cure from COVID-19. We are doing the time-based or the symptom-based strategy to say that you are cleared from COVID-19, but there's no need to repeat that test, either for discontinuing of isolation or if a patient within 90 days has a new fever, really look for something else that's causing that fever. It's really unlikely within 90 days that that's going to be a COVID reinfection. That's really not been found in the research so far. So the CDC is really recommending, you know, is there a wound infection? Is there a pneumonia? Is there a UTI? Please look around. But now really the new standard of care from the CDC and the Strike Force and CDPHE is to not retest these patients. And so we're hoping that we can partner with assisted livings, independent livings, that if we treat someone with COVID-19, they want to return, we shouldn't need to do a test-based strategy to say that they're cleared from isolation. Dr. Gahm, do you want to take the second half?
Sure, I got a bunch of things here. A lot of you have heard about the antigen tests that are being shipped out federally, eventually, I think, to all nursing homes. There are 6 so far, I think, in Colorado that have been identified. I don't know which 6. As getting them early, they're prioritizing places with outbreaks first. I'll inject my own opinion on these. I'm not looking forward to it. I think there are 2 major problems with it. Number one, the antigen testing was tested on people with symptoms, which raises anybody like Christine LaRocca, apparently, and I that really love statistics would know that the pretest probability in that group is already higher. So the test characteristics are going to be artificially inflated when you then try to use this test for anybody else. It's not a basic screening test. It's not ready for prime time, and it doesn't match PCR testing. So that's one problem with it. The second problem, you'll get the machine, one of 2 different machines, and you'll get 400 free test kits. So you can do 400 for free, which is just long enough to say, I've got the machine and everybody knows how to use it, and I'm hooked. We're going to stay with it. After that, you get to pay for the test. So it's like buying an inkjet printer, $50. You can go to Office Max, you can buy what looks like an expensive piece of equipment, $50. But then you spend $50 a week on ink. And the idea here is you're going to spend a fortune on tests that really are not for our population. So don't look too forward to that test coming. Mandatory staff testing, unfortunately, we didn't do it here in Colorado. State of Washington did it. The White House, about 10 days ago, said that they're going to mandate it in hotspot states. Well, luckily, we're not one of those, but we might be after school start. But it just isn't very valuable to do your staff and only get part of them. You really need to get everybody. Renee sent me some wonderful stuff on ADA in mandating it, but the governor and the folks at the health department and so forth were really quite clear that we're not ready to take that step yet. Antibody testing, I got a thing from the University of Colorado site saying, come on in, get your swabs, get your antibody tests. I was surprised by that because especially a university would hopefully, again, goes back to statistics and understand until the prevalence in the community is much higher. Antibody tests just are not a very good test. They're a really good test. If they're negative, there's a really good chance you just don't have it, pretty close to 100%. If they're positive right now in Colorado with our prevalence, the test is positive. There's only about a 60 to 62% chance it's actually positive. So there's just going to be, if there's widespread antibody testing, a whole bunch of people that think that they are protected, they must have had it, safe, don't need to wear a mask, I can go out to the club and dance and do whatever. It's just disaster. So they are not the answer yet. Schools reopening, I think, is going to be their next big wave because there are still factions that think that this is a hoax. I spent some time in Southern Colorado a couple weeks ago, and there are entire populations of people that think that this is all made up still, which is just scary. For those interested in discussing that still think that there are medications to use, join us on Thursday at Journal Club. we're going to discuss that. And as much as we want, I mean, the bottom line, as much as we want to help patients, give them something, even if it's just to provide hope, there are no medications yet that are going to change the course in our patients. Now, if they get sick enough and go to the hospital, get really sick, maybe dexamethasone, maybe remdesivir, maybe, but not our folks, our population, not yet. Turnaround times, good news, bad news, good news. The bad news is I don't think we were prepared for all the extra staff testing and community testing, and everybody, it's sort of reminiscent of what happened in April, where we got so backed up, it was averaging for a while 10 to 11 day turnaround time, which is completely useless. But even now through the health department in the past couple of weeks, it's been 6 to 8 day turnaround times, which isn't helpful. Doesn't help you make decisions, doesn't help you get those staff out of the facility. The health department has done everything that they can, got new equipment, they're running 24/7, new staff, they're catching up on the backlog. And my hope is that sometime this week, they'll actually catch up and we'll get closer to 2 or 3 day turnaround times. And Joe, I don't know if you know anything more about that. I haven't heard anything else, but I'm assuming that they're getting caught up. It'll just take a while. And then the last thing is actually a response to something in the chat line from Sylvia about residents coming and going. We actually pushed for putting an end to that, residents coming and going as they please for months. And then about 2 to 3 weeks ago, and Joe, you can elaborate on this too, on the Wednesday call, it came out that it is possible now, if you have people, patients, residents in your facility that choose to leave to do whatever on their own, you may educate them before they leave and document this clearly, that when they come back, you have to screen them, they have to wear a mask 100% of the time, and they have to isolate for 14 days in their room. If they refuse to do that, you are allowed to have them discharged, do an immediate discharge on those patients. Okay, that's all my updates.
Thank you so much, Dr. Gahm. And I know we are a little bit over, but we thank you so much for joining us. And we will do, I think we'll do another update perhaps next month. Next month, just to give you a heads up, we are the day